In this lecture, we will discuss how to approach a case of diarrhea. Diarrhea is one of the commonest presentation for which many individuals will be coming to OPDs and many times might get admitted as well. So it is very important to know how to approach a case of diarrhea. In this video, we have collected the information mainly from chapter 49 of Harrison and CMDT textbook. These are the sources for this video. First of all, what is diarrhea? Passage of abnormally liquid or unformed stools at an increased frequency. Generally, we will consider if more than 3 episodes of liquid or unformed stools are being passed in a day as diarrhea, or stool weight of more than 200 gram per day is considered as diarrhea. But practically, checking for stool weight is quite difficult. That's why we can consider the liquidity of stool with increased frequency as more than 3 episodes per day as diarrhea. But here important thing is, before working up for diarrhea, we have to consider few of the other similar terminologies, that is pseudo diarrhea. What does it mean? Frequent passage of small volumes of stool associated with rectal urgency, tenesmus and a feeling of incomplete evacuation. So here usually there will be small volumes of stool, but it will not cross the definition of 200 gram per day. So this we consider it as pseudo diarrhea. Mainly we see such situation in irritable bowel syndrome and proctitis. Similarly, the other terminology which we have to consider as the differential possibility is fecal incontinence, where there will be involuntary discharge of rectal contents, and it will be caused because of some neuromuscular disorders or anorectal structural problems. So these two things we have to rule out first before deciding it as a case of diarrhea. Now we will see some of the physiological factors which are deciding the gut motility and the usual stool passage. Mainly there are some extrinsic factors and some intrinsic factors. When it comes to extrinsic factors, parasympathetic fibers mainly through vagus nerve and sacral nerves like S2, S3, S4 will be helping out. Similarly, there will be some sympathetic fibers which will be handling the gut motility as well as this stool passage physiology. And the intrinsic factors are some chemicals like acetylcholine, VIP, vasoactive intestinal peptide, opioids, serotonin, nitric oxide, and intrinsic nerve plexus of GIT, myenteric plexus, and we know the pacemaker cells, that is interstitial cells of Kaha. So these are some factors which are deciding the normal physiology. So when we are discussing diarrhea, there might be some issue among these factors leading to increased frequency. So the ultimate result of this physiological dysfunction, that is, there might be either problem with the motility or fluid and electrolyte handling by the gut. So there might be increased motility leading to frequent passage of stools, or improper handling of fluid and electrolyte leading to increased liquidity or unformed stools. Or in some cases, there might be just increase in the HAPC, that is high amplitude propagated contractions. So what does it mean? Normally, high amplitude contractions will be happening in the gut, and we say about 5 episodes will be happening in a normal individual, and these are more evident after waking up and after meals. That's why we feel the urge to pass stools after waking up, and many individuals might be feeling the same after having meals. These are due to what? The normal high amplitude propagated contractions. But suppose there is increase in the number of this HAPC, it will lead to diarrhea or urgency. So there are numerous factors like any dysfunction among these factors leading to motility issue or improper handling of fluid and electrolyte can lead to diarrhea. Otherwise, in some individuals, there might be increase in the number of these contractions leading to diarrhea. So now we have understood what are the factors which are handling gut motility, and if there is abnormality in these factors, that will result in diarrhea. After understanding the definition and the similar terminologies as well as the physiological factors, now we will see how to differentiate diarrhea based on the duration. We call it as acute if the symptoms are lasting for less than 2 weeks. We call it as persistent diarrhea if the symptoms are lasting for 2 to 4 weeks, and if it is more than 4 weeks, it is chronic diarrhea. So this duration of symptoms is very important when you are dealing with a case. Suppose it is of less than 2 weeks duration and you are thinking it as acute diarrhea. Remember, usually it will be of infectious origin and often rapid onset, and it will be highly symptomatic. These are some clues. Whereas if the case is having the similar symptoms for quite a longer duration, that is more than 4 weeks, and you are thinking in terms of chronic diarrhea, remember, usually these are non-infectious and it will require systemic and structural evaluation. And the transition phase between acute and chronic is called as persistent diarrhea, and often it will be due to some refractory infections. Now we will see a case of acute diarrhea in which the symptoms are of less than 2 weeks. So remember here 90-10 split, that is about 90% of the acute diarrheal cases are infectious, whereas other 10% will be non-infectious. So majority is infectious, in which we have to look for the accompanying features like vomiting. Infectious means there might be fever, abdominal pain or discomfort. So these will be the associated features in infectious acute diarrhea. Whereas for non-infectious, where these accompanying features might not be evident. So what are the reasons for that? Mainly because of some medications like antibiotics usage, NSAIDs, antihypertensives, laxatives, antacids, and weight loss agents, even bronchodilators. So in your case, if there are no infectious features, you have to thoroughly evaluate all the medications which that individual is taking. Then, if the individual is above 50 years, presenting with diarrhea and lower abdominal pain, always suspect ischemic colitis, where there will be transition from watery diarrhea initially to bloody diarrhea over few days. So this possibility we have to keep. And the other reason might be colonic diverticulitis and some toxic compound ingestion like OP poisoning or toxic mushrooms, seafood, etc. So these are some non-infectious causes. So based on this, we have to ask the history for that individual. Now, as mentioned, about 90% of the cases will be infectious. So in that case, you have already asked the history of accompanying features like fever, abdominal pain and all. Now, you have to take the further history to search for the clue regarding the microbe which might be the causative organism. So what things we need to ask for? Many times the individual might be having diarrhea just because of some enterotoxins, that is mainly toxin driven. So in that case, there will be profuse watery acute diarrhea and the clue will be marked vomiting without fever. This is commonly seen in case of food poisoning, what we say. Food poisoning, especially after eating fried rice and all, there might be possibility of toxin ingestion due to Bacillus cereus. This is quite common. Whereas if there is high degree of fever, severe abdominal pain, but less prominent vomiting, we have to think of invasive infections, that is enteroadherent organisms, and there might be bloody diarrhea as well, which we call it as dysentery. So if these features are there, or in general, if the individual is appearing more sick, think of invasive microbes like enteroadherent E. coli or even Entamoeba histolytica. And here remember one more point. Usually these acute diarrheal infectious cases will be of mild severity and they will be often self-limited. So just they might be requiring supportive care. But if it is because of Vibrio cholera, it will affect small intestine. So how do we get to know that it is due to small intestine? There will be voluminous stool passage leading to severe dehydration. There might be hypokalemia, acidosis and even renal injury. So if these features are there, always think of cholera as the possible microbe. So here we got to know regarding some preformed toxin-mediated diarrhea, Vibrio cholera-mediated diarrheal presentation, and the invasive microbes leading to quite severe presentation. Similarly, we can take the travel history. If it is related, we have to think of enterotoxigenic E. coli as the possible microbe, or there might be chances of Campylobacter infection, Shigella, Salmonella. Similarly, there are some other clues like if there is history of having chicken, we have to suspect Campylobacter infection, Shigella and Salmonella again. This one I have already mentioned. Reheated foods like fried rice, where we have to think of Bacillus cereus, and if there is ingestion of mayonnaise or creams, think of Staph aureus, Salmonella. Eggs ingestion, possibility will be Salmonella infection again. Fresh or frozen uncooked dairy or mushrooms, think of Listeria as the possible microbe. And some seafood ingestion, always think of Vibrio cholera, Salmonella and hepatitis A. And in case of daycare attendees or community outbreaks, majority of the times it will be because of viral infections, commonly rotavirus. And in an individual who is being admitted in hospital, in that case if they develop diarrhea, we have to think of Clostridium difficile as well. So these are some clues we have to remember and ask for the history, so that we will get to know the microbe. Continuing with the clues again, in case of acute infectious diarrhea, if there are associated features of reactive arthritis, we have to think of microbes such as Campylobacter, Shigella and Salmonella infection. Similarly, if there is evidence of associated hemolytic uremic syndrome, always think of enterohemorrhagic E. coli or Shigella as the possible microbe. And the same individual is having autoimmune thyroiditis or pericarditis kind of presentation, even glomerulonephritis, think of Yersinia as the possible microbe. So based on the history, you might be thinking of some microbes. Now how to confirm it? The most accurate way will be to identify the DNA sequence of the microbe through stool analysis. But at majority of the places, this facility might not be available. So we will rely upon few other modalities like stool culture or looking for ova and parasite, stool antigen tests. But remember, these are quite less sensitive compared to the actual DNA sequencing, which is more accurate in evaluation. And if the case is mild to moderate, no need to work up to this extensive extent. We can just manage the case symptomatically, like we should support for fluid and electrolyte replacement, either oral rehydration solution or through intravenous routes. And we can take the help of anti-motility and anti-secretory drugs. Commonly, loperamide is used very often, but remember, take the help of these medications only if the case is non-febrile and non-bloody diarrheal case. Otherwise, avoid these anti-motility agents because they might increase the chances of toxic megacolon. And similarly, for anti-secretory action, many times we will utilize bismuth salts, that is bismuth subsalicylate. It will reduce vomiting and diarrhea to very good extent, but do not use this compound in case of immunocompromised or patients with renal impairment because of high risk of bismuth encephalopathy. This point should be remembered. And what about the empiric antibiotics? Initiate empiric antibiotics only if these signs are there. For example, signs of inflammation like fever, or the total counts will be more than 15,000, or if there is more than 6 episodes of diarrhea in 24 hours, in frail older individuals, hospital acquired diarrheal cases, if the individual is immunocompromised or having some systemic illness. In these situations, we can start empirical antibiotics. So what are the agents we can prefer? Mainly macrolides, and the dose is azithromycin 1 gram single dosage, or we can give it as 500 mg twice daily for 3 days. Otherwise, fluoroquinolones like ciprofloxacin 500 mg BD or ofloxacin 400 mg can be chosen. And if there is possibility of protozoal infections, mainly with the clue of contact with water, like consumption of contaminated water or diarrhea after the usage of swimming pools and all, in that case think of protozoal infections and add metronidazole. But at many places, especially fluoroquinolones, macrolides might not work because of the resistance. So in that case, nitrous oxide can be utilized. So this is how we will evaluate and manage a case of acute diarrhea. Then regarding persistent diarrhea, that is if the symptoms are crossing 2 weeks. As I mentioned, these might be because of some resistant microbes. So what might be those resistant microbes? Giardia infection, Clostridium difficile, Entamoeba histolytica, Cryptosporidium and Campylobacter. So these possibilities will be there if the diarrhea persists for more than 2 weeks. Coming to chronic diarrhea, where the symptoms are lasting for more than 4 weeks. So how to evaluate? In that case, the basic physiology understanding which we discussed in second slide will be helpful. That is, numerous factors, intrinsic, extrinsic, those might be having some issue, or the motility, or gut handling of fluid and electrolytes. So there might be problem in any of these factors leading to chronic diarrhea. For example, in case of osmotic type, there will be poorly absorbed solutes in the lumen of the gut, which will drag fluid, leading to excessive fluidity of stool, causing osmotic diarrhea. Whereas in secretory, there will be deranged fluid and electrolyte handling, leading to excess watery diarrhea. So if we look at the stool osmolality, in case of osmotic diarrhea, the osmotic gap will be more than 50. So this number we have to remember. The osmotic gap will be more than 50 in case of osmotic diarrhea, and it will be normal, no osmotic gap in case of secretory diarrhea, which we will understand in further slides. So whenever there is history of chronic diarrhea, we have to analyze it in various segments. For example, whether it is secretory diarrhea. What does it mean? Usually it will be of large volume diarrhea, painless, and it will persist with fasting. So it is mainly because of the improper handling of fluid and electrolytes. It is not related with the substance in the lumen of intestine. That's why whether the substance is there or not there, it doesn't matter. So even if the individual is fasting, in that case also the same issue of fluid and electrolyte handling will persist, leading to secretory diarrhea. And as mentioned, there will not be any fecal osmotic gap. Whereas in osmotic type of diarrhea, we mentioned that because of the improper absorption of substances in the intestine, they will drag the fluid. So if we fast, that is when there is no trigger in the lumen, in that case there is nothing to drag fluid. So this osmotic type of diarrhea will cease. So this is one of the differentiating factor, and the osmotic gap will be more than 50. Another type is steatorrheal diarrhea, where there will be fat malabsorption, and if we ask the history, there will be greasy, foul smelling, difficult to flush type of stool, and there will be history of weight loss. Whereas the other category is inflammatory chronic diarrheas, where it will be accompanied by pain, fever and bleeding per rectum. But in this one, the mechanism might be a mixed type. It might be due to fat malabsorption, hypersecretion or hypermotility. The other category is diarrhea due to dysmotility, where there will be rapid transit of the substances. So what happens is, whenever any food substance is passing through the intestine and all, it should pass at a normal speed so that the digestion and absorption will happen normally. If the transit time is very short, these substances will pass very fast without getting properly absorbed. And we know that in case of rapid transit, small intestine as well as colon might not get sufficient time to reabsorb fluid. And if you know, daily about 10 liter of fluid is being exposed to the gut, where about 8 liter will be reabsorbed by small intestine and about 1.5 liter will be reabsorbed by the colon, finally ending up in the loss of hardly 200 ml. So this is the normal capacity of the gut to reabsorb fluid. When we don't give sufficient time because of rapid transit, in that case, this fluid reabsorption will not happen properly, leading to secretory type of diarrhea. Now we will see what might be the causes. We have understood how these 4-5 different categories of diarrhea will be presenting with. Now what are the reasons for those? Mainly when it comes to secretory causes, there might be some medications causing it. For example, laxatives, olmesartan, NSAIDs, the recent one GLP-1 analogs, PPIs, and some toxins ingestion like chronic alcohol intake will damage the enterocytes, leading to improper absorption of the fluid and electrolytes, leading to secretory diarrhea. Similarly, arsenic toxin will damage enterocytes, and sometimes because of the inadequate reabsorption of the bile acids, mainly in case of bowel bypass surgeries or bowel resection surgeries, even cholecystectomy. In all these situations, bile acids will directly reach colon, where it will stimulate the secretion of fluids, leading to secretory diarrhea, which we call it as bile acid diarrhea. This point also is very important. So this is one of the reasons for secretory diarrhea. And as mentioned, the issue in those factors which are handling physiological gut motility. For example, numerous hormones. If there is excess in the levels of these hormones because of tumors, commonly carcinoid tumors, gastrinoma, VIPoma, medullary carcinoma of thyroid, and even the other hormonal issue like Addison's disease. So all these will alter the gut's physiological function, leading to secretory diarrheas. When it comes to osmotic causes, we know that it is because of the improper absorption of the food substances, commonly carbohydrate malabsorption. You might be knowing about lactose intolerance and wheat malabsorption, leading to osmotic diarrhea. Coming to fat malabsorption, mainly because of pancreatic exocrine insufficiency, which will happen in cases of alcohol ingestion due to some medications or cystic fibrosis cases. Similarly, some other malabsorption diseases like celiac disease, tropical sprue, Whipple's disease, even HIV enteropathy, all these will lead to malabsorption. So if you see here, there might be passage of greasy, foul smelling stool, which will be difficult to flush. And these individuals, because of chronic malnutrition, they will have nutritional deficiencies like anemia, even edema because of protein deficiency, and there will be some features of fat soluble vitamins like vitamin A, D, E, K and all. So these are some clues regarding steatorrheal diarrhea. When it comes to inflammatory causes, where the diarrhea might be associated with fever, abdominal pain, and sometimes bleeding per rectum. So in that case, we have to look for leukocytes or leukocyte derived protein in the stool, that is calprotectin. And the common etiologies for inflammatory diarrhea are ulcerative colitis, Crohn's disease, and microscopic colitis, eosinophilic gastroenteritis, and autoimmune enteropathies. So for these, we can take the history and we can look for leukocytes in the stool or leukocyte derived proteins. And if it is there, work up further with colonoscopy and biopsy. And the last section was regarding dysmotility related diarrhea. So conditions like hyperthyroidism, carcinoid syndrome, diabetic neuropathy, even irritable bowel syndrome will have the general mechanism of rapid transit. And I have explained it already. When there is insufficient time for the gut to reabsorb fluid and all because of rapid transit, excessive fluid and electrolytes will be lost in the stool, leading to the appearance just like secretory diarrhea. So after all these, the framework for chronic diarrhea evaluation should be like this. First, ask in history regarding the number of episodes. For example, if there is many number of stool passage, think of small intestinal pathologies. If the episodes are few and there might be some associated features of large intestine involvement like tenesmus, urgency and all, in that case suspect large intestinal pathology. And ask the history of nocturnal diarrhea, whether it is present even at night or not. Usually in case of irritable bowel syndrome, this nocturnal diarrhea will not be there. Then ask the history regarding relation of diarrhea with food intake. If it is worsening after food intake, suspect osmotic diarrhea. If it is remaining unchanged even at fasting, think of secretory diarrheal causes. Also ask stool character. Suppose it is watery, think of secretory causes again. If it is greasy, foul smelling and difficult to flush, think of fat malabsorption, where we can again ask the history of chronic pancreatitis or some malabsorption disorders. And always ask some of the associated symptoms history like fever, uveitis, bleeding per rectum and all might be giving a clue towards inflammatory bowel disease, or if there is weight loss and some warning signs in elders, think of colon cancer as well. Associated symptoms like weight loss, anemia or some other nutritional deficiencies, always think of malabsorption syndromes. And how past history will help us? Ask regarding history of bowel surgeries, even cholecystectomy and all, where we will be able to work up towards bile acid diarrheas, BAD, and also ask the history of diabetes, thyroid disorders, HIV, and thoroughly take the details of all the medications which the individual might be taking. So before considering for the investigations, all these factors will help us in finding the probable cause for chronic diarrhea. So do not miss to take this history. When it comes to lab evaluation, if there is presence of pus cells, leukocytes or leukocyte derived proteins like calprotectin, think of inflammatory bowel disease. If there is presence of blood in the stools, again inflammatory bowel disease might be the reason, or colon cancer. Fat presence in the stool points towards chronic pancreatitis or malabsorption disorders. Presence of ova or parasite points towards chronic infections. And stool electrolytes and osmolality will help us in differentiating secretory versus osmotic diarrhea. And finally, structural evaluation through colonoscopy, endoscopy, especially in case of malabsorption disorders, flexible sigmoidoscopy, even colorectal biopsy are very crucial in diagnosing inflammatory bowel disease, even carcinoma of colon. So these are some investigations in case of chronic diarrhea. Coming to the treatment, we can take the help of anti-motility drugs like loperamide, but do not use it in inflammatory diarrhea. Usually initial dose will be 4 mg and we will be keep on giving 2 mg after every diarrheal episode, and maximum will be up to 16 mg per day. And if it is secretory or diabetic diarrhea, we can use clonidine, but there will be chances of postural hypotension with this medication, so the patches are preferable in case of diabetic diarrhea and secretory diarrhea. Regarding octreotide, this is specifically indicated for secretory diarrheas caused by neuroendocrine tumors. We have seen many residents, even practitioners, prescribing octreotide in other causes of diarrhea as well. But remember, it is mainly indicated for secretory diarrhea due to neuroendocrine tumors. And the dosing will be 50 micrograms subcutaneously thrice a day can be given, and we can increase up to 250 microgram TID. And in case of bile acid diarrhea, we have to advise for some bile salt binders like cholestyramine 2 to 4 gram. These are some medications. Again, once we have diagnosed the exact cause for chronic diarrhea, accordingly we can take the help of these various pharmacotherapy. And finally, just to revise the entire lecture, when patient presents with more than 3 unformed or liquid stools per day, ask regarding the duration. If it is less than 2 weeks, it is acute diarrhea. If it is more than 4 weeks, it is chronic diarrhea. In acute diarrhea, majority of the times it will be infectious, 90% of the cases. And if the case appears to be severe, do not hesitate to start empirical antibiotic. And majority of the cases will respond well with just symptomatic therapy. Whereas in case of chronic diarrhea, take the detailed history to identify what is exactly causing this chronic diarrhea, and osmotic gap will help us in deciding whether it is osmotic or secretory, and some of the stool characters and lab parameters will help us in deciding whether it is steatorrheal diarrhea, inflammatory diarrhea, or dysmotility related diarrhea. This was the entire discussion regarding approach to a case of diarrhea. So before sending for investigations, always follow this pattern to identify the probable cause. Then according to that, we can choose the investigation to be sent. This approach is very important because many a times we have seen individuals will be presenting with chronic diarrheas but are being treated again and again with some antibiotics and all, which is not required because numerous chronic diarrheas will be non-infectious in origin, as discussed in detail in this video. So please make notes out of it and keep your own flowchart for approach to diarrhea and try to follow it in all the cases so that we can avoid unnecessary treatment as well as unnecessary evaluations.